develop into squamous cell carcinoma. So those are very commonly frozen. There are some topical therapies such as Effudex or Aldera. These are creams that some people don't want to have surgery, so you can apply creams to the areas. It's typically reserved for skin cancers that are very superficial. They can't really be used successfully on skin cancers that have more thickness to them. Lastly, I'll talk about Mohs surgery. Some of you may have heard that term, Mohs. A lot of people come in, who is Mo? What is Mo? It's different from Larry and Curly, I always like to point out. But it's named after Dr. Frederick Mohs, who passed away a couple years ago. It's actually been around for a long time. It's a surgical procedure to remove skin cancers. But I'd say it's gained popularity in the last 15, 20 years. And it's used very commonly to get rid of skin cancers. What's good about this form of treatment is that it allows the dermatologist to examine the entire area that's removed to make sure that all roots and extensions of the skin cancer are gone. It has the highest cure rate of all forms of therapy for skin cancer, and because of the methods that's involved, it leaves the patient with the smallest possible scarring also. It's most commonly used for basal cell carcinoma and squamous cell carcinoma. It's very rarely used for melanoma. People are studying it with different stains and different methods to try and have it be used more frequently for melanomas. It's an expensive and time-consuming procedure, so it's not used for all forms of skin cancer. The way this therapy is done is similar to the others in that it's typically an in-office procedure. The patient comes in with a known skin cancer. We numb it up with a needle again. Then, instead of cutting out a larger area to make sure it's all gone, we cut out a small area. That part only takes a couple minutes. And then the patient has a hole, and they wait about a half hour or 45 minutes. I take that piece of skin and I give it to a tech. The Mohs tech will take that piece of skin, freeze it, stain it, slice it up very thin so I can examine it on a microscope slide. Now the patient's still waiting. I look under the microscope, check all the margins to make sure that the whole thing's out. If there is still a little bit of skin cancer left, I know exactly where it is, and I can go back to that specific area and just remove the necessary part. If there is no skin cancer left, then we're done with the first part, which is removing the skin cancer. Then, after the skin cancer is gone, and you leave the patient with a small hole, then they usually go for stitching, either by dermatologists. Occasionally, it's done by someone else, like a plastic surgeon or an oculoplastic surgeon, if it requires that. Because it's a time-consuming procedure and expensive, it's not used for all skin cancers. It's used for skin cancers that are recurrent, tumors that have a high chance of being recurrent, if they're in cosmetically important areas, especially the face, or if they have ill-defined borders to them. We're wrapping up now. In conclusion, you need to protect yourself from the sun. We talked about wearing the protective clothing and using the sunscreen. I recommend everyone see a dermatologist on a yearly basis, but check yourself out on a monthly basis. Again, make sure to check all the parts of your body, backside, breasts, feet. Bottom of the feet are a common place that people don't check. If you see a sore that won't heal, a pimple that won't go away, you think you have a skin cancer, you know the A, B, C, D, E, Fs of melanoma now. If you have new, changing, or just a funny-looking mole, see your dermatologist.
This program was brought to you by the Boca Raton Community Hospital Foundation. Imagine what we can do together.